Good afternoon, everybody, and thanks a million for joining us for today's webinar on CDM Phase 2. My name is Donald O'Neill, and I'm the Head of Marketing for Clonwilliam Health, and with me, as always, I have Louise Murray, who is our support team lead for Socrates. The goal for today is Louise is going to run through an overview demonstration of CDM Phase 2 in your Socrates system. As always, we will take as many questions as we get, as many questions as we can get through at the end. So if you have any questions, there's a little tab on the right-hand side of your screen called questions. Type them in there, they'll come through to me, and I'll do my best to put as many of them to Louise as I can at the end of the presentation. And again, just thanks to so many of you for joining today, and hopefully the session is useful. In terms of the rollout for CDM Phase 2 is due to start next week, and it should be deployed to all Socrates users by sort of a couple of weeks after that. So we wanted to do this webinar before that, basically, so that you can hit the ground running and start using it straight away. And hopefully we'll be able to go through kind of any questions or any information that you need really to make CDM useful for you. So without further ado, I'm going to pass it over to Louise, and Louise will start the demonstration. That should be on its way to you now, Louise.
Yep, let me see here. Okay, can you see the screen there now?
Can indeed, yeah.
Hello, everybody. Right, okay, so we will start off with just kind of the basic information first of all. So I'm going to go through in this webinar, I'm going to go through the opportunistic case finding and the prevention program, and I'll go over slightly over chronic disease management itself. So when it comes to chronic disease management itself, it's now 18 and over that you can do a chronic disease management on. For opportunistic case finding and for prevention program, it's 65 plus. So to be able to use this, you need to have basically the same thing as chronic disease management. You need to have a HealthLink cert to be able to submit it, and you need the PCRS cert to be able to validate the GMS cards as you do them. So, right, if I go into a test patient here. So I'll just show you actually straight off the bat. Sometimes chronic disease managements, so it'll apply to opportunistic case finding and the prevention program, but your GMS number needs to be correct inside of Socrates, and it needs to have the correct, you need to have the same date of birth as what the HSE have on record for the patient. So sometimes what happens is when you're trying to send off a CDM visit, it will ask you, it'll say, well, that date of birth isn't right. So if you wanted to check to see if someone's date of birth is right, I have test patient here, Joe Blogs. And this is the person's address, and this is their GMS number, their expiry date, and this is what I have for their date of birth. If I go in here, it is just, this is checking the PCRS and what they have on record. So in here, we have the 16th of the 9th, 1937, and that is the correct date that I have. But sometimes it'll say the date of birth is wrong, and it might be off by a couple of days, and all you have to do is get it, change it to the same date the PCRS have. So if I click on save and close to this, so I'm going to go into consultation with Joe Blogs, and I'm going to fill in some basic information. This person is empty. So baseline details, I'm going to say they are, I'm going to go with, oh no, 150, no, what am I doing, 100, I'm going to go with, I'm going to say you can fill in the head circumference, all this normal stuff that you would normally fill in a baseline detail. I'm going to say that this person is a current smoker and they smoke about 20 a day. And I can also say they drink. And I can fill in this stuff here. If I go whatever you would normally have, I can fill in all the information about my baseline. Save and close to this here. So now I have a baseline. You don't have to fill in the baseline at the start, but it's just good to have it in your patient's chart as it is anyway. So I'm just going to put in a blood result for this particular patient. You have you just happen to have the blood results in for these people. So I'm going to go to begin a consultation, basic training there, and go into investigation. So you would normally have bloods in. My example is you just happen to have maybe the bloods back by paper, or maybe the patient was in the hospital and you just happen to get some blood results back. So I'm going to fill them in here. So instead of having to redo the bloods in the patient, but if you would normally take bloods for the person. So in here, I am
Louise,
going
sorry to interrupt you. We just had a question in on bloods while you're talking about it there. Do they get prompted at every visit as to what bloods the patient needs?
No, like if it's you, when you're the doctor, you choose what bloods I need to do for this person.
Okay.
So it's not prompting you, oh, you have to do a hemoglobin or something.
Sure.
If you wanted to do a blood test on a person, then you probably have your own routine bloods that you would take.
Okay, cool. Thanks.
So I'm just going to fill in some dud information here. I'm going to just make this person's blood results some normal and abnormal. And one. I'm going to say, so along those lines. I'm going to say 100 and 8. I'm just going to put that into review. But you would normally have your bloods in here. I just don't actually have real blood, so that's the reason why I was doing that. So if I go into care protocol, chronic disease management. So if you're all familiar at this stage, I'd say, with chronic disease management. So when it comes to the opportunistic case finding, the point of it is the patient happens to be in with you for something. It might have been just a routine blood test you might have done with them, or they've come in with a totally different reason. They might be getting headaches or whatever it is. You just happen to have an opportunity to do this on the person. So if I go in here to add review, I have in here now an option to choose between opportunistic case finding and chronic disease management. So I don't want to do a chronic disease management of this person because I don't think they have anything yet. So opportunistic case finding, I click on that, and then it says case findings for patients identified with high risk of cardiovascular disease or diabetes. So I click OK to that. This window pops up, once again similar to CDM. In here you've got review date is today, reviewing doctor. I'm going to have it as just the doctor that works here. These aren't real doctors. And ethnicity, white Irish, air code. And it's coming up with indication for review, like why did I decide I was going to do an opportunistic case finding. This person is a current smoker, and their BMI is pretty high, so I'm going to go current smoker, and I can also tick that. So tick whatever it is, the reason why you're doing it, multiple reasons or one reason. And I'm just going to say current smoker. Over here on the right hand side, it's validating at this stage. When I click OK, it's validating the person's GMS card to make sure that it is correct. So my example earlier when I was showing you the date of birth was, it will flash here and it will say, oh, that person isn't right. That's not that, we don't know who that is. So I'm going to say OK to that. And this window pops up. Over here on the left hand side you have opportunistic case finding, so it's now going to be in individual headers. So opportunistic case finding, or what most people are going to end up abbreviating it as, is OCF. So an OCF, I have the name of it here, the registration, the review date, the reviewing doctor, created by us, and status incomplete. And its indications, I ticked earlier that they're a current smoker. It's automatically brought in my height, weight, BMI. So in here we have height, BMI, waist circumference in centimeters. In here we have the exclamation marks, and there are the mandatory fields. So if I hover over it, it's just saying mandatory fields. So I'm going to go waist circumference. If there was a baseline filled in, it would bring in the last 6 months, but I haven't put in a waist circumference, so I'm just going to put one in here. And if there's no pulse rate, once again, that would have come in. I'm going to start putting in invalid stuff here because that mightn't be correct. Regular, irregular, blood pressure, smoking status. This person is a current smoker. So this is a new option here where it says vaping status. This is new in chronic disease management. That's a new feature or a new question that needs to be answered. So I'm going to say vaping status. They've never vaped before. In here we have the QRIS3 score. If I click on the button with the 3 dots to the right of that, it is basically calculating this for us. And if you needed to fill in any of the rest of this information, you would check it. So this score is 31.1%. If I say OK to this, now it's calculated there. So it's automatically brought in my hemoglobin, total cholesterol, HDL, etc. This applies when sometimes what happens is people's blood results don't automatically link into the patient's chart, because we have been able to sync certain bloods because different labs around Ireland call it different things. For example, we call it here total cholesterol, and in our Socrates, the lab we're saying uses the word total cholesterol. Some other labs might call it tot-col or something along those lines. The one for HDL might be down as col HDL. So basically, we need to say, if it ever comes across that it's not automatically bringing it in for you, you have to sync it one time. So unless the lab changed the name again. So in our example here, ours is working fine. So total cholesterol, if this was blank, as in it didn't fill in a total cholesterol, you could, so you basically search for it. And what I would do is I generally go back to the consultation, go into my investigation and look at my blood result. I double click on the result, and then I basically find out what it's called. So ours is called that. But if it was something like tot-col or something that's not what Socrates is automatically knowing. So I'm going to go search for it. You basically click on the button with the 3 dots, and you have the option to search by name. This one is automatically working because it is correct. So if I was to, you basically can search for it, and so you basically search for it, and then what will happen is you find it, but we didn't have to search very hard here, it was already here. You double click on it, and then a window will pop up asking you, do you want to remember this for next time? And then you say yes to that. And then any chronic disease management, OCF, whatever visits you do, they will automatically go in correctly then. So in here, we have the opportunistic case finding outcome. We can say normal or prevention program or diagnose with chronic disease, register on treatment program. So after doing this OCF on the person, we now can choose, well, what's going to happen here? Are they fine? Do we need to put them on a prevention program, or have they been, we realize they have a disease and we need to register them? So in our example, I'm going to say that we're going to put them on a prevention program. And in here, it's when I choose prevention program, it's asking me why am I doing this? Why do I need to put them on a prevention program? And you can say, all right, their QRIS3 was greater than or equal to 20. Up here, you can see ours is pretty high, so I'm going to say that's the reason why. If there was any other reason, you basically check whichever reason it is that you want. Let's pretend that we're not actually going to put them on a prevention program. We're going to put them on the chronic disease. We're going to click on that, and then it's giving you, well, why are you doing that? And then you can say, the reason why they're type 2 diabetes after we've worked out. So we tick on that, and then when you do a chronic disease management on the person, it will automatically know that you have selected diabetes type 2. I am, as I was saying, putting them on a prevention program. So I'm going to click, oh sorry, I forgot to say, if they're normal, there's nothing that has come from this, that everything is perfect. We don't need to do anything with them. They're healthy. We don't need to put them on any prevention program. You can submit it there and then. Once that opportunistic case finding is done, the next time you can do one is in 5 years' time. I am saying I'm putting them on a prevention program because I'm worried about them. So I'm going to say the cure risk 3 greater than or equal to 20. And I am going to click on save to this. At the same time, I'm going to submit it. So I'm going to go click on submit. And at this stage, it's checking the GMS number. And then it's sending it off to through HealthLink. When you send off these visits, it does 2 separate things. It goes to 2 different departments. One, it goes to the PCRS and the GP application suite people, and they are basically authenticating the GMS number, and they say, yeah, you're going to get paid for that. That's perfectly correct. This is your patient, etc. Then the second thing that it does is it goes to the clinical people, and what they do is they process the content of the information. The height, weight, BMI, all the information that you sent off, that's what they are looking for. Now, theoretically, you could have been taking bloods today, and you're not going to be able to fill in the rest of this opportunistic case finding for another few days. So, but if you happen to take the bloods and they have come in today to talk about the bloods, then you can do an opportunistic case finding. I have sent this off, and now theoretically I can actually do a prevention program straight away on them because I have all my bloods back. In here, when I go add review now, so sorry, I think I'm doing that slightly too fast. I go add review, and in here we have a couple of different options. One, prevention program. The opportunistic case finding is not in here because I've done one and you can't do another one for another 5 years. And the other option is I can register them on the chronic disease management. I'm going to put them on a prevention program. So in here, it's basically saying patients with high risk of chronic disease are enrolled in this program. So I say okay to this. And similar window comes up like we saw earlier. And its review date is today. Reviewing doctor is going to be doctor again. And yeah, so there's the review date. In here, it's brought in from my opportunistic case finding that I checked Q risk 3 greater than 20% registered on 2022. In here, it's doing the same thing in the previous visits where it's checking to see this number is valid, and if it's not valid, it's not going to let you go any further. I don't need to check anything else here because I'm just saying this person's Q risk was greater. So if I click on the OK button here now, it will open up the prevention program. So we're calling it prevention program, but it's probably people are going to call it PP just for short. In here, we have on the left-hand side, we have from earlier the opportunistic case finding, and then now we have the prevention program. In here, we have the name of the program, the registration, review date, reviewing doctor, who created it, status is incomplete. We have the prevention reason. So I said it's because they're Q risk. It's brought in my baseline details, and it's brought in BMI. It hasn't brought in waist circumference and stuff like that. So I'm just going to put in some stuff. It doesn't have to be the same as last time. I can't remember what I put in last time. So in here we got pulse rate, regular, blood pressure is this, weight, brief intervention. So in here, this person is of high risk with their BMI. So there is the brief intervention checkboxes. So I'm actually, just so you can see what happens, if this is a mistake up here and their weight and height is wrong, you can technically change it in here. So as you can see here now, this is a high risk person. If I change this to 80, you can see that it's changed it to low risk. And if I change it a bit further, I should do 90 actually. 90, so we got increased risk. So I'm just going to put this back to the way it was, which was weight of 100. So I'm going to answer these questions. So the different questions based on the risk factor. So this is a high risk person. If I hover over this here, weight intervention option required for submission. So if you ever see an exclamation mark, you just hover over it. So in here, I'm going to say, right, yeah, I've spoken to the patient about their BMI. If you see the blue play sign, you basically can click on it and it will bring you to some material that you can give the patient. And then I'm going to say, yeah, I gave that to them. I didn't refer them to a dietitian and patient declined, not interested. That didn't happen. This person is a current smoker. So I'm going to say you have to basically fill in some, check one of these before you can go any further. Brief intervention. Yeah, I gave them an intervention. Then signposted to HSE quit service. Once again, I click on this play sign. It will bring us straight to the website where we can get material to give the patient. And referred to HSE quit service. Yeah, I did that. I did not prescribe them any medication, and they did not decline, so that's fine. Vaping status. I'm going to say they've never vaped. And in here we have now the alcohol risk score. If I click on this button with the 3 dots, it's going to come up with the tool here that we need to fill in. So I'm going to fill this in a couple of times just so you can see what happens. There's 3 fields here that it's asking us to fill in. How often do you have a drink containing alcohol? And you can say 2 or 3 times a week. Actually, sorry, I'm going to go 2 to 4 times a month. How many drinks containing 10 grams of alcohol do you have on a typical day when drinking? I'm going to say 3 to 4. How often do you have 6 or more drinks on one occasion? I'm going to say never. So I don't have to fill any more questions in. That's perfectly a good score. It's low. It says score 3, low risk 0 and 7. So I'm going to change this around and I'm going to say I'm going to drink 2 or 3 times a week, and I'm going to say 3 or 4 as well for the units, but I'm going to say monthly. On how often do you have 6 or more drinks? So that's opened up more questions that we need to fill in. My score currently is at 6, and so depending on how I answer to these questions depends on what my risk is. How often during the last year have you found that you were not able to stop drinking once you had started? So I'm going to say yes or never. How often during the last year have you failed to do what was normally expected from you because of your drinking? Never. How often during the last year have you needed an alcoholic drink in the morning to get yourself going after a heavy drinking session? Never. How often during the last year have you had a feeling of guilt or remorse after drinking? Never. How often during the last year have you been unable to remember what happened? I'm going to say never. And how have you or somebody else been injured as a result of drinking? No. Are people worried about you? I'm going to say no. So my risk score is low. So I can change this and my risk score gets higher. And you can see now I'm at a higher risk because I've answered them differently. I'm just going to say this person is a score of 10. So they're an increasing risk. If they were, it can get higher. But yeah, so I'm going to say risk score of 10. So depending on what I filled in here, depending on what I need to say in here. So there's a brief intervention. Yeah. Once again, click on the play button and it will bring us to the website where you can get material. Patient declined, not interested. That didn't happen. In a typical week, how many days have you been physically active for greater than or equal to 30 minutes? So depending on how I answer this, the same thing applies here. Not days, I have to fill in more information. If I say no information available, then I don't have to fill in anything else. Unable to be physically active, I don't have to fill anything else in. 5 to 7 days, I don't. So the first 2 are what I need to fill in. So I'm going to say 1 to 4 days. In 4 days or less, in a typical week, have you been physically active for either 150 minutes, moderate, or 75 vigorous? I'm going to say yes. If I said no, then there will be an intervention. I have to fill in. I'm going to say I do. I'm fine. So in here, we got the Q risk score again. And in here, it's the same information as we saw in the OCF section. And in chronic disease management, I'm going to leave this as fine. I'm going to say okay to this. Has patient ever had an ECG? Yes. Fill in the details of when it was last. I'm going to say no. Has patient ever had an echocardiograph? Yes. Fill in the details. I'm going to say no. In here, it's automatically brought in the bloods, so I have nothing else to fill. Nothing else to fill in. Down here at the bottom, you can see there's 6 fields that I still need to fill in. So if I click on the little arrow to the right of that, it will bring me straight to the section that I need to fill in. So if I change this to education provided, it brings you to that section. So thyroid function test, no. Liver function test, no. Education provided by GP, yeah. Agreed with care plan, yes. And then medication review, I'm going to click on the view button. It's bringing us straight to the prescription section. I've reviewed. Come back here and say, yes, I've reviewed that. So in here, prevention program outcome, diagnosed with chronic disease. I'm going to say no. If I say no to that, what will happen is when we submit this, sorry, I changed that to yes by accident. If I say no to that and save and submit, what will happen is it will submit, and you aren't saying that they've got a chronic disease management, so they don't have a chronic disease, so you don't have to do, you're going to get the prevention program now, you can do it again in 9 months time, so every 9 months. OCF every 5 years, PP every 9 months. So I'm going to say diagnosed with chronic disease, I'm going to say no to that, and I have my care plan that I can fill in. So you fill in your care plan similar to chronic disease, and you fill it all in, and then you can save it and print it off. Not really going to go through this section because you just basically fill in the details. So I'm going to go back here to here, and I'm going to save it and send it off. Save, and I'm going to click on the submit button, and off it goes. Then in here, if we decide, technically you can do three visits, 3 of these in the same day, an OCF, a PP, and a chronic disease management. It's very unlikely that will ever really happen, but it is theoretically possible to do that. If you, after doing an opportunistic case finding and then doing a prevention program, you could technically add chronic disease management. It's very unlikely that will ever happen, but it is an option. I just wanted to just say some small things that are new in the chronic disease management section. I'm just to show you what's new. So I'm going to say okay to that, and I'm going to say they have every single disease, just so you can. So these are new. So yeah, these are the new ones in here. This one here and this one here. Yeah, those are the 2 new ones. Yeah. So I'm going to say okay to that, and now I am going to just to show you the chronic disease management. So in here, the new ones that you have to have is the vaping status of the patient. That is new. Smoking status, you can say current smoker, and the vaping. Yeah, so vaping status here, that is new. The intervention section, that's new in the chronic disease management. The other thing that's new is under vaccines, you have the COVID vaccine. It's now a mandatory field in here. And then the audit C tool that we saw in basically the C tool that I showed you in the PP and the OCF, that's new. Then we also have the creatinine is a new section. This isn't for all diseases, just the creatinine one is new. So that one will automatically calculate for you. So it's using the patient's age sex, creatinine, and their weight, and it automatically calculates it for you. Yeah, so they're all, that's what's new in that section, but it works the same way. So I'm going to just close this here for a moment, and I'm just going to show you some other things. So if you needed to, first of all, it's a good idea just in general. We'll send out notifications to people. So up here at the top right, you've got notifications and you have news articles. So in here, we'll point out some news articles that you can, we send them out every few months. And it's basically we'll send out updates on this in relation to chronic disease management. So just have a read, just have a look at them every few days, just to see if there's anything new coming up about chronic disease management, or literally anything. The news section up here, people don't realize is there, but it can be quite helpful if you're trying to figure out something. In here we have the reports. So there's some modifications to the reports. You have report section. Check to see if you ever have any updates available. In this one here, we have 4 updates available. When it comes to, if you have no updates available, it'll literally say no updates available. These reports in here under the search section, if I look for CDM now, that's new. We used to have to look for the word chronic to find these chronic disease management reports, but we've renamed them. So if there's modifications made to this to include the OCF and the PP visits. And in here, if I just go to updates available, I've left them in here because I just didn't want to install them just yet. Just because I wanted to show you. So if I wanted to install all the reports, I click on this checkbox and I go install. I'm just going to install one just so you can see what it looks like. So I'm going to click on install, and you can see this is downloading and now it's installed. You won't see in your current versions of Socrates a new report to download, because you just need to be on the new version to be able to download this report, because you need to have OCF and PP to be able to use the report. So in the new version, it'll be in there. So the chronic disease management reports, if you wanted to look for it manually, it's down here at the bottom, or as I was doing there, search for a report. That's those ones there. I'm just going to actually just double click. I'm going to just do the due ones, just so you can see. So I'm going to go, I want to see everyone that's due for them for the next year. So in here, you can see it says PP annual review, CDM review, etc. We're not going to have any OCFs due because it's 5 years, you have your next one. So you're not going to see any OCFs on your report for 5 years at least. So I'm going to close that. Then I'm going to bring you to the chronic disease management section to look at the status of all your visits. So under my control panel, we have claim tracker. And from here, we have different sections, but we have chronic disease management, which is what we want to look at right now. So there's some slight changes made in here as well. So for example, these 2 are unsent, and they are of type CDM and a type PP, so chronic disease management and a prevention program. So those are the unsent. These are all the incomplete ones. These are the CDM visits. In here we have awaiting acknowledgement. So for example, there's the Joe Blogs ones that we sent off. They leave the awaiting acknowledgement when we get the responses back from HealthLink. So whenever HealthLink has the responses, they download with your bloods, same way that chronic disease management ones did. Then we have the accepted ones. So these are all our accepted visits, our accepted PPs, CDM, and OCF. So I want to show you some rejected ones. Now, before I actually click on the rejected, this is a testing Socrates. So there is a lot of reusing of numbers. So there's a lot of rejected sections in here. If I wanted to point out some things that people don't realize, if you wanted to check a status of a certain visit, like why is this one rejected? If I highlight this Sandra Test Doyle patient, on my keyboard, I'm going to press Control Alt and the letter A. So it will open up this section here. From here, we have CDM review audit details. So Control Alt and A after highlighting the visit. In here, as I was saying earlier, this is the reimbursement message. So this is the PCRS payment people. This here says status accepted. So they have been accepted. You're getting paid for it. Down here at the bottom are the clinical people, and this particular one, they have rejected it. So you're getting paid, but the content, the clinical people didn't like it. So over here on the right hand side, it will give you the reason for it. Now, this error, you're never really going to see this. It's just because there's so much testing going on this one. If you ever come across, I'll try and get the right one. I had one earlier, and now I can't find it.
Oh, it's away.
There is so many visits in here. Right. If you ever get a message where the PCRS, so I'm going to open up this Sandra lady here for a moment. If you get the reimbursement message and it says that it's accepted, the clinical people have rejected it. So if you ever get an error where it's basically saying OBX5 missing file, what that means is, so as I was saying, payments are accepting it, clinical people are rejecting it. So what that just basically means is the clinical people are getting some information from you and they're expecting some other something else, some bloods. So you have certain bloods that you take on the patient and the clinical people are saying, oh, no, there's the bloods missing there's bloods missing. That should be fixed in the versions coming. So what that means is you'll be able to, if you ever get a rejected clinical message, you'll be able to submit it again. So just leave them in your rejected list, and when you start getting your new version, you should be able to resubmit them, and in turn they won't come back as rejected anymore. Yeah, so if you wanted to see the status of your rejected list, so they're rejected, but doesn't mean you're not getting paid. So this one here, this one has been accepted, rejected. So I am pressing Control Alt and A on the visit, and it's given me the reimbursement message, accepted, rejected. So if you want to see the status of your visit, that's how you do it. And if you hover over the right hand side of the messages under rejected, it'll give you the reason as to why they are rejected, and it will help you figure out what exactly is wrong. The other thing I wanted to point out was pretty much the last thing. It's just if you needed to find out some, basically on the manuals, if I go to the home screen, we have the training webinar. So after this webinar is finished, Donna's going to be putting it up on our YouTube channel, and in there you'll be able to rewatch the video that we've just done. And then in here we've got user guides. This brings us straight to the Socrates website, and on the Socrates website we have all the manuals on chronic disease management and any other manual that you may need. If you wanted to have some information on just the chronic disease management program, you can find out that information on the HSE website. If I click on this website here, it's basically chronic disease management program. You can just look at the information on the chronic disease management. It's on our manuals here. That website that I've just gone to on the chronic disease management. So here's the chronic disease management user guide, the one that we've just gone through. And we also, on this here, we have a link to the website if you wanted information on chronic disease management in relation to the HSE. You can click on that and it'll bring you straight to the HSE website on it. That's pretty much it that I wanted to go through with everyone. But do we have any questions, Donald?
We have a load of questions to these. So look, I will fly through them rapid fire style because I'm conscious of everyone's time, but I think that was a really worthwhile overview. Okay, look, without further ado, first things first, Louise, for OCF and PP submissions, is it just the GP that can submit that, or can it be done by a practice nurse as well?
Yeah, a practice nurse can submit them. Yeah.
Great. And sorry, I'm literally just scrolling through them here to find the questions.
Just one thing. For example, I'm not a nurse and I'm not logged on as a doctor or a nurse, and I was submitted those visits.
Okay, brilliant. And then in terms of the OCF itself, is that only applicable or does it only work and find patients who are over 65, or is it all patients, or how does that work?
Yeah, so for OCF and PP, you need to be 65, age of 65 plus. In the coming years, or I think it's in the next year or so, the age bracket I think will go down to like 45, but that should be on the HSE website it'll be on this section here, I think.
Okay.
Um, yeah, so in here
Then,
you can see this is the phase table for the HSE. The opportunistic case finding, age 65 and over, but in the year 2023 they'll be able to do 45 and over. The same thing with the prevention programs. So yeah, prevention and OCF have a similar time frame.
great. And then secondly, is one reason enough to generate an opportunistic case finding, as in one area of illness, I suppose, like, or can you do an OCF for someone with hypertension, for example?
Yeah, if I go in here, like if you feel that they need to kind of go on a plan to help them with their condition so they don't develop it, then yeah, you can put them on a prevention program.
Great.
I think that's answering the question.
It is. Well, sorry, it's answered it for me anyway. But sorry, if anyone has any follow-up questions, they can email them into support@clanwilliamhealth.com, and the guys will get back to you as quickly as possible. And then, sorry, is there a list of criteria for the OCF in the same way that there is a list for criteria for CDM, or is it the same list?
When you do an opportunistic case finding here, if I can, my mouse working. Maybe if I go in here to this opportunistic, so go. It's on the window that you see. I just don't have the window. On the window that when you're adding it, if I can go into someone that hasn't. Don't know if we have any patients that doesn't have an OCF in their chart. They all have, every single one of our patients has one, so I can't get the window open first.
Okay, no worries.
But say on the front screen, so like there when you're adding the OCF, there's options as to why you're checking to see. It's not a condition necessarily. Like they're a smoker, so you want to say, all right, or their BMI is really high. You want to maybe just check to see if they're at risk. So you don't necessarily have a condition. It's kind of more like it's an opportunity to check to see if they
Okay.
have them.
Yeah. Okay. Okay. Cool. Moving on. If they identify diabetes in OCF, will that code back to the patient's chart?
Yeah, exactly. If it
Yeah.
hasn't already been, yeah, exactly. It'll go back into the chart. Yeah.
Okay. Great. And then, sorry, bear with me for a second. Sorry, I've just lost the questions here. And sorry, is it possible to transfer hospital bloods to a CDM file return?
Yeah, it's pretty much something similar to what I did there. I didn't technically have electronic blood, so my example was that the patient had gone to the hospital, they were in there, they got bloods taken, and then you don't want to go and redo the bloods unnecessarily. The hospital has sent them on to you. If you don't have one in here already, like this one here in my test patient here that I was using, I added an investigation called non electronic results. This is the one that we have just in this Socrates. If you don't have one in your one, you can just give the support desk a call and we can help you add that in the
Great.
background.
Great. And you actually answered the next question I was going to ask there as well, and that was great. On medical cards, so does the GP who is on the patient medical card need to be the one to complete and submit, or can another GP within the practice submit?
Another doctor in the practice can submit. So you can, you got a doctor here, myself, Dr. Louise, but I don't have a panel. I don't have, no, these patients don't belong to me. They're not under my list. So it's belonging to, they're under Dr. Dolan here. So I submitted that off, but I was selecting her as the doctor that we're sending it off on behalf of. So that window that I was talking about, where you just basically, it will tell you if the date of birth is wrong as you're adding the visit, that's the name that will go get sent off with it.
Great. And then, sorry, 2 seconds there again. How do you display the CDM review audit panel? Sorry, is there any other way other than Control Alt and A? Is it possible to right click it that in that example you gave us there?
No, it's the Control Alt and A. You can do that from the patient's chart as well.
Okay.
Well, technically there's two options, but it does the exact same thing. It's Control Alt A or Control Alt and E. They both do the same thing. I don't know why we've got them there twice, but yeah, Control Alt A. Listen here, Control Alt A. Brought it up, and then I'm going to do it again, and I'm going to press Control Alt and E instead, and it's brought it up. So those are the only options: Control Alt A or Control Alt E. You can't open it up any other way.
Okay, cool. And then if the OCS is done and then you move on to CDM, do you get paid for both, or is it just the first submission? That might be more one for the HSE rather than us.
Yeah, exactly. I can't be sure on that. It might be on the HSE website that will tell you that basically, but we're not too sure of that.
Yeah, we're more here about the system rather than the payments behind it. And then is there an alert system for when the patient needs to be reviewed, or is that managed from the reports and kind of you review it yourself to manage that?
It's managed in the report section. The ones you'd point to those reports that I was showing you there. You basically would run that maybe, well, depending on how you want to work. The reviews due, run it once a day or once a week or once a month or whatever it is that you decide. But that's how you would monitor it, of how to do it. There is an option as you are doing. You can set alerts in the chart, and you can set. If I go in here for a second, patient maintenance, open patient, Joe blogs. You can have an alert in a person's chart. You can say there's different types of alerts. There's an appointment alert, there's an account alert, and there's a consultation alert. So if I add an alert under appointments, it will put up a message to say you have whatever it is when you're booking an appointment, an alert will pop down in relation to whatever it is. In our examples here, we're saying their CDM is due. Accounts, once again, when you're charging the person from the waiting room or inside the account section, an alert will pop down. Wouldn't really be beneficial for this particular scenario that we're talking about. But then you've got the consultation alerts, which will pop up an alert down at the bottom. So if I just show you here, if I go, you can put in CDM due, and you can, I could spell correctly, CDM, I'm going to say PP is due, and it's starting today. You can say that it's actually in the future, but I just wanted to say it's today for testing, showing you purposes. And you can then go save to that. I'm also going to add it in under the consultation. So if I click on consultation, I can put in the same message there. I want to leave it as today's date and go save. So if I go to the appointment diary and I book in an appointment for that person, it will pop down an alert to say PP due and the date of it. Once you say, all right, do you want to book in your PP, or do you want to do that? Then you can say, yeah, that's done, and you can check it off. or if that was a mistake, you can click on the red X, or if you want to keep it there, you just leave it alone. I'm going to say no, I don't want to book an appointment. If I go into that same patient again, go into Joe Blogs, I should close out of them just to show you it. Consultation, Joe Blogs, an alert is popping up down at the bottom saying PP due. Once again, if you're finished with it, you've done the PP on them, click the checkbox, or if it was a mistake, click on the red X. So you can basically put a batch alert on all charts that are in that bracket that we're talking about. So we want to know everyone that's due the last that's due basically. If I go under consultation, sorry, wrong thing, patient maintenance, and then over on the left hand side you have patient group alerts, and this is linked to the report section. So if I go load group, I have the patient and I have my chronic disease CDMs due, and I want to know everyone that's due from today basically. And there's very little in this particular chart. So these 5 people are due. I can basically send off a group alert for all of those. Create group alert, and I can, the same thing that we saw in the patient's chart, we have an appointment alert, counsel alert, consultation alert. So if I go in here to PP's due, I'm going to say that one is due, and I'm going to do it again and go chronic disease management, PP's due. That's just an example. You can call it whatever it is, but that's what I said. And then we have it in, those alerts are in those 5 patients chart. If you've made a mistake, you can delete it, and the actual group alert. If it was me, what I would do is I'd run the group alert like once a week and then delete it every so often. So if I go patient group alert, I can load the history and I can see that I have created an appointment alert that went into 5 people's charts. I created a consultation alert that's gone into these 5. If I just double click on these appointment ones, I can see what 5 got this alert, and you can say, oh, I don't actually need that in Sandra's one, that was a mistake. Or Ronan test was actually completed. And so that alert is in all those 5 charts, but I'm after taking it out of 2 of them. So then if you wanted to, you could just basically delete it in its entirety every so often, because maybe it's just, you might have done it 2 years ago and you just don't want it anymore. So patient group alert, group alert history, I don't want that anymore. It's in 3, active in 3 charts, deleted in 1, resolved in 1, and it's in 5, it was in 5 in total. I'm just going to highlight it and I'm going to say delete or resolved. I'm going to delete it. So I just don't want to look at it anymore. So you could do something like that if you're talking about trying to do an alert, but basically the main report that I was talking about is the first port of call to review people.
Okay, cool. That's really useful. So again, look, again, conscious of time, but I'll fly through a couple of last questions here, Louise. Can you go straight to CDM after completing the OCF, or do you need to fill in the prevention program first?
Yeah, that's no, you can go straight to it. But I just remembered something there. Someone reminded me when that question reminded me. If you have someone in general that you are monitoring, like you in the practice as is before this version comes out, you probably monitor people because they're maybe on the verge of being diabetic, pre-diabetic. You monitor them anyway. So to get them on the PP program, you need to do an OCF first. So they come in, you do an OCF, and then do a PP. You can't go straight in to PP.
Okay.
But yeah, you can, yeah, you don't have to do those. You can put, if someone has got heart disease or whatever it is, they've got a chronic disease, you can put them straight on to CDM.
Great. And then in terms of the Q risk, can Socrates calculate that automatically, or does it need to be sort of manually updated before it calculates?
Kind of like what yeah, I think I get what you mean. Claim tracking, chronic disease, incomplete. I'm going to go with this one here. This one isn't mandatory in this particular chart. See, in here, there's some bloods and stuff that it needs. So you need to open it up and say okay to the message for it to come in, because you need to go in here because you might need to fill in one of these things. I think that's what they're asking. Do you have
Yeah.
to open it up? So yeah, you have to open it up because you might need to click on something else, and that's kind of
Okay.
making sure that you go in and do it.
Okay, so it's a checklist effectively. Um, cool. So if a patient has started the program and say stopped a year ago, can they be re-registered for it, or will they always be on it? If you know what I mean, and then you would just pick it up when they come back in.
Are Repeat that question there. Is that got to do with prevention program, or is that talking about a chronic? Oh yeah.
I think
If
it's
you put
CDM.
someone on
Anyway,
a
yeah.
chronic disease management, you can't put them on a prevention program. Once they're on CDM management, once they're
Okay.
on a chronic disease, you can't do it. So say if someone has asthma, as an example, you've put them as a chronic disease management, they have asthma, and that's the chronic disease they have. You can't have a PP on a diet if you're worried about them becoming diabetic. Once you're on CDM, you're on CDM, and you can't do an OCF or a PP on anything else.
Okay. Okay. Cool. And then, sorry, I just had a response in there. The question about acute risk was for all patients, not just once they're on CDM, and it's around the doing it for case finding.
Is that under here, kind of like a baseline
I
thing?
think so. Yeah.
Um, yeah. So basically, no, the Q risk. Q risk. I'm really sure it's only in. So there's a CVD risk. In here. This is what. This is what you see. This is what you're. This is it here.
Hmm.
And this is what we're talking about. So you can
Okay.
repeat that question again. Sorry, Donna.
Sorry, it's actually gone, but it's around. Sorry,
Do you need to be on CDM to be able to do a Q risk?
exactly. Yeah.
Yeah, so no, you can do it in here under
Okay.
baseline.
Great. And then, look, I think we'll call this the last question. In terms of, can you text a group of patients to advise them to arrange CDM visits?
Yeah. So just one thing on that. Um, an OCF, you're not going to be going, all right, I'm on the new version of Socrates now. I'm going to call in all these OCF people. It's an opportunistic case finding. It's not you going out of your way to try and find it. It's just mainly you have an opportunity with the person to have them there, and you do the visit on them. You don't call people in looking for them. Once they're on a prevention program, then you can continue to use the reports to bring them in. If you already have kind of like in-house at the moment, you have prevention programs, but it's just not called prevention program in your office. Just you always do. You monitor patients to make sure they don't get on the verge of some other disease. So if you have the way you return them in, maybe it's like you review the prescriptions every so often, and maybe it's you have an investigation that you add in to kind of monitor people. Whatever it is, the way that you normally call people in to monitor whatever it is that you want to monitor, you continue doing it the same way, and then you can then add them to a PP program in-house in the chronic disease section.
Okay. Okay, look, Louise, that's absolutely brilliant. I know we kind of went on much longer than we thought we would, but I think there was a huge amount in there, and hopefully it was really valuable information for everyone on the webinar today. If we didn't get to your question, chances are it might be one that's for the HSE rather than us, but please feel free to drop us an email. You can reply to myself or Louise or the support team, support at Clan William Health, and we will do our best to answer any that we didn't today. And again, huge thanks to Louise. I appreciate there's a lot in that, Louise, and it's a very comprehensive overview that you gave us. So that was great. And thanks to everyone for attending today. This video will be live on YouTube from this afternoon onwards. Thanks a million, everybody, and we'll
Thanks,
talk to
everyone.
you soon. Thanks. Bye.
Bye bye.